Hello, I'm Dr. Michael Wexler from National Jewish Health, and I'm joined by Dr. Eileen Wang for this clinical brief on biomarkers and predictors of response for biologic therapies. One of the things that's really important to evaluate in our patients with severe asthma are the characteristics of all the biomarkers. So let's review the importance of exhaled nitric oxide. Exhaled nitric oxide is a substance that is made in our airways by nitric oxide synthase genes. It's produced in the lungs, and it's an indirect biomarker of type 2 high eosinophilic airway inflammation. In particular, it's produced by interleukin 13, and IL-4, IL-5, and IL-13 can all play a role in terms of upregulating nitric oxide. Currently, there are several handheld analyzers that can accurately measure nitric oxide in terms of parts per billion. And this is an important discovery because it allows us to pinpoint and decide which patients may benefit from targeting of IL-13 via IL-4/13 receptor, such as what dupilumab does. Now, one of the things that we've learned is that it's important to have biomarkers that are predictive as well as good monitoring biomarkers. In terms of prediction, what has been shown is that there's a significant association between patients who have high exacerbations and who've got high nitric oxide or high eosinophil count. With regard to nitric oxide, the higher the nitric oxide level, the more likely that patient is to have an exacerbation. Similarly, when there's a combination of higher nitric oxide and eosinophils, this can result in exponentially increased risk for asthma attacks. So you want to evaluate blood eosinophils and nitric oxide because these are both excellent predictors as well as potentially monitoring biomarkers in patients with asthma. So in terms of biomarker-guided biologic selection, is there a gold standard? Well, FeNO and blood eosinophil counts are quite consistent in terms of being associated with efficacy of the biologic therapies, particularly the eosinophils with anti-IL-5, nitric oxide and eosinophils with dupilumab, anti-IL-4/13 therapy, and anti-TSLP therapy responds best in patients who have higher blood eosinophils and ENO. The probability of response to all these treatments relates to the intensity and consistency of the signals of the biomarkers. And it's important that clinically important responses to anti-IL-5 and anti-IL-4/13 become apparent, and they increase progressively with eosinophil counts as they get above 150. There's a greater response in terms of patients who have eosinophils above 500, greater than above 300, greater than above 150. But the better response to treatment for a particular eosinophil count are seen when both eosinophils and nitric oxide are raised. So you want to evaluate both of those biomarkers.
Now, looking at the differences in terms of these biologics on the effect of your biomarkers, so you can see for fractional cell nitric oxide, dupilumab, omalizumab, and tezepelumab did have an effect in decreasing this, but the anti-IL-5 and anti-IL-5 receptors did not have a significant effect. In terms of IgE levels, dupilumab, omalizumab, and tezepelumab also were shown to decrease this. It's important to note that omalizumab actually can increase your total serum IgE, but it's decreasing the free IgE. In terms of blood eosinophils, as you would expect, the anti-IL-5 and anti-IL-5 receptors, such as benralizumab, mepolizumab, and reslizumab, decreases significantly. Tezepelumab has also been shown to decrease this, and dupilumab has been shown to have that risk for a transient increase in the peripheral eosinophils. For sputum eosinophils, all but dupilumab has been shown to decrease this.
Eileen, how far has the understanding of the relationship between biomarkers and predicted response come in the last 3 to 5 years?
As I mentioned before, I think there's been some great advances in terms of our understanding of the pathogenesis and mechanisms behind a lot of asthma inflammatory pathways, and you mentioned hyperresponsiveness. airway hyperresponsiveness. And so we do have all these biomarkers that you talked about that help us with this precision medicine and personalized approach. They're much more accessible to and relatively cost effective. However, a lot of these are not direct biomarkers of many pathways. For example, we don't really understand the non-type 2 or type 2 low mechanisms at play and don't have great biomarkers looking at that. And so there is still a lot of room for growth and development here. But it is exciting time as we start to see and grow this understanding in our data, and also in these clinical trials of biologics has shown us, for example, the fractional cell nitric oxide being predominantly mediated by that IL-13 pathway, but also with effects from IL-4 and IL-5 that came from these studies. We saw that the anti-IL-5 and 5 receptor biologics didn't really have that significant impact on decreasing fractional cell nitric oxide as we were expecting.
Yeah, I think these biomarkers have been very, very useful in terms of helping us guide our therapeutic approach. Beforehand, without the biomarkers, we tried a one-size-fits-all approaches. And really what the biomarkers have taught us is that each individual is a little bit different. Some have high nitric oxide, some have high eosinophils, some have both, some have neither. And then you throw into it the other comorbidities as well as the propensity to allergies, and it can really help guide us in terms of selecting therapy for our patients.